basically the presentation is primarily discussing refracting keratoconus patients. Now, my experience in this specific region, which is, very niche, comes from a lot of work that I took part in Moorfields, London, where we were refracting keratoconus patients for a keratoconus monitoring clinic. And one of the recurring themes that the practitioners discussed was refracting smarter, not more. Okay, and more chair time doesn't necessarily translate to better results when we are refracting these keratoconus patients. The lecture itself was actually, we had a UK optometrist come over and join us recently in Moorfields, Dubai. And it started as a bit of a training for her to give her a better starting point. And then after a discussion with Stuart, he thought it might be something worth sharing. One of the points to remember is when we're discussing these keratoconic patients is that often when they sit in your chair, if they haven't had any refraction before or have had no optical aids, they're used to dealing with weirdness. Okay, and we'll define that weirdness a little bit more as the presentation goes on. I guess a good place to start is sort of what is keratoconus. And we know that keratoconus usually affects the eye slightly differently. Okay, and if we look through the definition, it's a progressive, non-inflammatory, bilateral, ectatic corneal disease. And this definition is really, really important. Progressive. We know that it gets worse, okay, especially during those early years or, mid-teenage years, late teenage years, into that sort of 20-year-old, 25-year-old category. Those are the ones that progress the most, and then this slowly tapers off. So we know it's a progressive disease, non-inflammatory. Now, when we speak about non-inflammatory, we're talking about the cornea itself. There have been some inflammatory markers found in the tears, but not the cornea itself. And bilateral. Keratoconus is a bilateral disease, okay? Although it often can be very asymmetric, the disease itself is within the corneal tissue. Quite often it's this combination of environmental disease and the genetic factors that contribute to it manifesting in one eye more than the other. And one of the things I found really interesting was there was a study, and basically it looked into the prevalence within males and females, and it actually affects males and females quite equally. But often the males present with a more advanced form of keratoconus. Now, the study didn't exactly give us the reasons why males present with it more advanced. My theory is that, women generally wearing eye makeup have a little bit more self-restraint, whereas males tend to, put the knuckle in and really start rubbing the eyes. And I think it's probably that self-restraint that limits how fast the disease is progressing. One of the other quite interesting things is generally the keratoconus will be worse in the dominant hand. And again, that's probably because these people are studying or working, dry eyes, itchy eyes, putting the pen down and then really start rubbing the eyes. And it's something that's, working with a lot of keratoconic patients, it's something that really does tie together, which is shown in the literature. Then it's characterized by a paraxial stromal thinning or a weakening that leads to this distortion. And we'll discuss the distortion a little bit more going on. But what I really want you to do is concentrate on that initial definition, okay? So progressive, non-inflammatory, and bilateral corneal disease. We need to ask, how common is this? How common is keratoconus? Now, there's not a lot of actual UK studies done on the prevalence itself. But if we take the United States, which is another sort of very mixed population of mostly Western descent, we're looking at about 1 in 2,000 individuals. Now, the average practitioner, the average optometrist in the UK is probably seeing around about 1,500, 2,000 patients per year, which means that you're probably likely to see at least one keratoconic a year, depending on the population that you see, the age group that you see, and a few other environmental factors of where your practice is based. Now, this 1 in 2,000 changes dramatically when we're speaking about Asian or Asian Pacific populations, where it's 4.4 to even 7.5 times greater than what we would see in the Caucasian population. There was a really recent study actually done in Saudi Arabia, which is obviously close to where I'm working at the minute, and they've even reported between 20 and 25 patients per 100,000. So the study itself went on to look at one specific province called the Najan region, and because this had quite tight genetic links, and there was quite a lot of these small population groups, it was even found as high as 83 cases per 100,000. Okay, partly genetic, partly the dusty environmental factors as well that we deal with is why we see it so high within the Gulf or within the sort of Arabic community. So it's something to be aware of when the patient does sit in your chair. And then whenever we're talking about the onset, generally this starts to take place around about the age of puberty. Now, that's very different for every patient of when puberty starts and when this disease can take hold. Generally in the sort of Indian subpopulations, it tends to progress more rapidly and younger. Okay, so those high cells, young Asian patients, you really need to be very astute in making sure that you're picking up the early keratoconus cases and getting them referred into clinic. We know that the earlier onset is much more likely to need surgery because the disease will more rapidly advance through those late teenage years and early 20s. And again, I just want to reiterate, you're probably going to see a few of these patients every year. Okay, so it's not this mysterious disease that hides in the shadows. It's something that you will pick up on if you take into account a few of these little techniques, which we will highlight today. These patients that we've highlighted, who are the ones to watch? If I have a patient in my chair, the questions I always want to ask, or the questions at the front of my mind is, high astigmatism. Okay, do they rub their eyes? Don't necessarily concentrate on the young patient's answers. You want to also ask the parents sitting in the chair. Quite often these patients don't actually realize that they're rubbing the eyes for a long time when they're studying, when they're reading. So make sure to ask all the family that's in the room. Is it something that they've noticed that maybe the patient themselves hasn't? Atopic patients, these are the ones that's going to get the keratoconus early, and these are the ones that's going to progress at a much faster rate. So the big ones are asthma, eczema, and hay fever. If I see any of these red flags, it's going to make me or sort of prompt me to get a pentacam done or some type of topography to highlight any of those very early signs. Again, we want to be marking these patients early and getting them in the clinic to get the cross-linking done. And the last one's Down syndrome patients. Down syndrome patients are much more likely, sort of 10-fold, 20-fold times higher to have keratoconus. Also, sometimes the communication isn't as good with these patients in describing some of the vision problems that they have. Okay, so again, just take a second look take a few extra minutes and really hone in on some of these patients to watch. What's important to remember is the quality of life that these patients have. And whenever we look at the CLEC study, so this was basically assessing the quality of life in various different aspects: mental health, role difficulty, driving and dependency, and even ocular pain scores. Keratoconus was put in the same category as either category 3 or category 4 age-related macular degeneration. And the conclusion from the study was that this magnitude of the public health impact, it's disproportionate to its prevalence and clinical severity. This is something that takes hold whenever people's lives are forming. So whenever those patients are starting a new job, whenever they're starting a university, when they're making friends, when their careers are budding, they're hit with this visual difficulty, which has the same impact as macular degeneration. Okay, so this really, really affects people's mental health, and we need to be aware of this disproportionate impact that keratoconus can have. Now, it's not all doom and gloom. Okay, we've spoke quite a bit there about the keratoconus can often leave these patients feeling a little bit deflated. But again, we're the optometrists. We're here to help them at the end of the day. And the good news is that there's lots we can do for these patients. What I like to do is, with a keratoconic patient, treat the patient and not just the eye disease, okay? And I like to set a goal, find out, is their goal driving that they haven't been able to do? Is their goal playing golf? And try and aim the vision or the achievement of good vision to that goal, okay? And quite often I'll use the term 6 happy, okay? And this was coined from one of my friends, Matt Ronnie. Whenever we were training together, he used to use this quite a lot, and I still use it today in clinic. 6-6 is fantastic, and it's great to be able to tell the patient, this is the level of vision you're reaching. Unless the patient's an optometrist, they don't spend their day looking at sight test charts. Okay, so 6-6 does not translate to the real world, and we want to find their goal and try and match it to that. So as I said, treat the patient and not just the eye. So this ever-shifting target, and anyone that's refracted a keratoconic patient knows that this multifocality can cause a variable endpoint. The variable endpoint isn't just frustrating for the practitioners. This is something that's incredibly frustrating for the patients, and quite often they do dread coming in to have a refraction done or to see an optometrist for refinement of their prescription. But we can generally improve their quality of life with a refraction, so it's the best place to start. Good news is, spontaneous human combustion is very rare, so be brave when you're refracting them. The endpoint's not always clear, but that's okay. We really want to make sure that the eyes are well lubricated before we start refracting, and that's one of the top tips I'm going to start with here, is make sure the eyes are well lubricated. This will smooth out the refractive surface, covering in some of the lumps and bumps. And it's a little bit like an uneven floor. If the floor is wet, it makes the floor that little bit more even and will help you get a better endpoint. When you're involving the patient in a refraction, quite often you get the question, why aren't glasses correcting my vision? Why is this not as good as I want it to be? And generally I just sit down with a pen and a piece of paper. It takes a few minutes, but you would not believe how many patients have had keratoconus for 20, 30, 50 years, and no one's actually explained to them why glasses don't work so well. This is one of the earliest discussions I'll have with a patient, usually before I even start refracting. And a diagram, something as simple as this. So, you've got your cornea and the light obviously passes straight through, nice and clear. When we're discussing a keratoconic cornea, and I always say this is for demonstration purposes, this isn't an exact piece of artwork of the topography maps, but this keratoconic cornea causes light scatter, and you want to be using these type of terms with the patient. So light scatter, and we know as practitioners that's from these higher order aberrations, your trefoil, your coma, and this is what's really causing the shadows, the halo, the glare. Now, what does that look like to the patient? Well, if we put a glasses lens in front, it still doesn't clarify the issue of the corneal multifocality of this corneal irregular surface. And obviously, an irregular surface results in an irregular image. And once the patient sees this very small doodle, generally it starts to make sense to them. Okay, this is what we're dealing with. He understands why I can't see well, and it builds that level of trust nice and early. This is one of the examples of a dry eye patient basically with keratoconus, and you can see here how quickly the tears break up. Again, it's a bit like an uneven floor. It will dry unevenly if the corneal surface is irregular. So unless you start using the lubricating drops nice and early, you will just be chasing your tail around. Again, the second the patient blinks, that surface has already started breaking up, and you can see there some of the superficial punctate epithelial erosions. That cornea is never going to refract to 100%, given the irregular nature of the staining. Okay, so 5-10 minutes before you start refracting, make sure you've got the eyes well lubricated. So your greatest ally when you are picking up keratoconus or when you're testing for keratoconus isn't a pentacam, okay? And some people aren't going to like this, but it's the retinoscope. You wouldn't believe how much this picks up. 97.7% sensitivity in one study and 98.8 in the second study. If you look with a retinoscope, you will find those higher order aberrations, those split reflexes, those irregular swirling oil drop reflexes. And trust me, if you're unsure at any point, pick up a retinoscope. Okay, if the K readings are a bit odd, if the autorefractor's lost its mind, if the prescription's going around in circles, pick up the retinoscope and you will very, very quickly learn the irregular nature of that cornea and why you seem to be chasing your tail. So please, please keep this to hand at all times in the clinic and don't let it just gather dust. And the conclusion basically that the study summarized was, it showed a clear clinical use in confirming the diagnosis of keratoconus. Now, this isn't picking up keratoconus, this is actually confirming it. And they placed this against an autorefractor and a pentacam, and this one actually came out the #1 tool. So how useful are the autorefractor results? Somewhat useful is what I'm going to say. It's useful to use yourself combined with retinoscopy to clarify where the prescription is. Now, what I mean by that is that if you go down the garden path in your refraction, it's useful to come back to the autorefractor and say, okay, now that we've done the subjective, pop in the autorefractor results and see with this subjective, is it actually better than the autorefractor results? You want to compare those two. because sometimes a patient can make one image or one of the shadows clearer, and then whenever you go back to the autorefractor results, sometimes actually that was a better starting point. And quite often whenever we take these autorefractor scans, patients are very eager to know, okay, what's going on? Is my eyes getting better? Are they getting worse? What's happening here? And you've just got to let them know, this is a process that takes some time, and we're still very much refining it at this stage. So the first starting point was retinoscopy or autorefractor, which is always good. If you have access to pentacam, so tomography or corneal topography, this can be another very, very useful tool. So let me go a bit closer here. What we're looking for here is the flat and steep axis. So when we're looking at the pentacam itself, we can see here that we've got a flat axis just along the sort of 120 degrees or roughly. Steep axis is around about 40. Okay, and we've got the right and left eye respectively. Now what I want you to do is look at the shape of the flat axis. Okay, so look where it is. So left eye sitting slightly temporal, right eye's also sitting slightly temporal as well. Some of the figures I like to look at on a pentacam when I'm doing a refraction is, okay, what's the corneal astigmatism showing? So here we've got the corneal front surface is showing about 3.6, 3.5 diopters of corneal astigmatism. And that gives me a really good idea of what kind of numbers we're expecting. The Kmax. The Kmax is useful in differentiating if this is mild, moderate, or advanced keratoconus. So the Kmax of 46, almost 47, we're dealing with a fairly mild case of keratoconus. The corneal back surface. The corneal back surface will actually cancel out some of the corneal front surface. Okay, and this is another really, really useful thing to note in a pentacam or some of these more detailed tomography scans. If we just look back at the pentacams a little bit more, the two axes that became apparent or became highlighted in this case were that sort of 120 degrees and about 75 degrees. So these slightly temporal flat axis or cylindrical axis became apparent. The third starting point, so once we've got our retinoscopy autorefractor, once we've looked at our topography, if you can't find another good starting point, this is something I really want to highlight. Now, if you have absolutely no idea where to start in a keratoconic patient, try one of these. +2 with a -4, sphere equivalent 0, okay, at 90 degrees, should get you at least on the board to refine further. Now, the moderate isn't sphere equivalent. It's actually a slight plus prescription. But these two starting points were advised to me by one of my seniors back in London, and you will be amazed at how often this will at least get you down the right path to start the subjective refraction. I don't know why it works. It's possibly witchcraft, but if you put this in the trial frame, this is a really, really good place to refine further. When we're refracting the patients, one of the things that people forget is that, trial frames can be immensely useful when we're specifically dealing with these corneal irregularities. The reason for that is that the patients can see much better what they're looking at than you ever can. So put the prescription in the trial frame and get them to refine it themselves. Get them to twist the axis, get them to find the best points. And sometimes what I'll do is go through a full subjective and ask them to try and refine it further. Get them to figure out where the axis is. And then sometimes you can shift the axis 10 or 15 degrees, ask them to do it again and see if they go back to the same point. This lets you know how reliable or how accurate that refraction is likely to be if they keep finding the same endpoint. And we want to use larger steps as well, depending on the vision. You know, plus minus 050 sphere, plus minus 050 sill. And obviously, if their vision's good, then you're going to want to use slightly smaller steps. Or if it's more difficult, bigger steps. The refraction itself shouldn't take you any longer than 5 to 7 minutes. The reason why I'd like to keep the refractions short is because, you know, the patient will get frustrated. The eyes will get dry from not blinking, not refreshing that tear film. And after about 5 or 7 minutes, you just end up going around in circles. So it doesn't seem to be of much benefit or much additional benefit after this. If you're refracting, make sure to do it after the contact lens is removed. Okay, if these patients are wearing RGP lenses or scleral lenses all day and they're going to use their glasses in the evening, make sure to refract them just once the lenses are removed. There's no point in them taking the lenses out for 2 days and then getting the refraction, because the prescription will be way off from what it will be at the end of the day after wearing lenses. When we're using the pinhole, okay, this is something to be careful of, okay? And I use this more as a tool to show patients what their vision can be like when we remove the higher order aberrations. So again, if their vision is not good enough, this can be a way to say, okay, this is the best that we can get with spectacle lenses, put in the pinhole, and then say, look, this is potentially what we could maybe get with a contact lens, you know, and see if that makes a big difference to the overall vision. When we're prescribing, we want to reduce the sill, but obviously keep the spherical equivalent the same. Now, these patients, as I said at the very beginning, they're used to seeing, like the photograph suggests, these weird higher order aberrations, blurry vision. They tolerate much more cylinder and much higher astigmatism levels than someone that's, you know, not a keratoconic patient. So a normal patient that comes in with 2-3 diopters of cylinder, you're going to be very hesitant to prescribe the full. I would be much more confident in prescribing these weird prescriptions or these higher astigmatic levels in a keratoconus patient. They manage much better with it. And you really need a superstar dispensing team behind you. Okay, so if you're given the full prescription, make sure that they're getting glazed in-house so that there's no extra charge to the patient if they don't tolerate the full prescription. You know, obviously your lens size, your centration, these are things that the dispensers will absolutely, you know, be all over. They will, you know, make sure that the patient takes your results and gets the best possible result. The other thing is explaining to the patient that if they tilt their head a certain angle or look through the bottom edge of the frame or do something, you know, some abnormal head position, they might get a little bit better vision, but obviously that's not something that we can incorporate into the glasses. And it's having both an optometrist and a dispensing optician that are aware that these patients will try everything to get that little bit better, and just sort of reaffirming to the patient that, look, given the fact that we have to center the lenses, this is the best vision looking straight ahead, but you might catch some of the aberrations from the lenses and it might actually improve the vision slightly. And just letting them know that that's something that we expect. BVD is always important. You know, when we're prescribing these high cells, high sphere, anything over ±4 sphere equivalent, make sure that you've got a BVD on there. If the vision isn't where you want it to be, use this as an opportunity to discuss contact lenses. And the reason actually why I've used this moon photograph as an example is one of my patients that I had about a month ago, their goal was to see the moon clearly. I haven't seen the moon clearly in years, and we got them refracted up. We ended up going down the contact lens route, but this was their goal. And, you know, this little photograph just reminds me of the importance of finding a goal and not just a vision level. If the glasses don't get good enough results, use the diagram that you've used before to explain to them, let's give you this pseudo cornea, this smooth ocular front surface, and give you that clear vision, to achieve the goal. And with this, the patient can very easily see why glasses maybe aren't giving them 100% vision, and maybe why contact lenses might be a better option in the future. And again, if you look at the example on the left, so this is a corneal impression that we took. You can see there the irregular shape of the cornea, plus then the blue dome over the top. That was the corneal contact lens that we designed. And you can see that the difference is absolutely night and day whenever we molded that into the green lens at the side. That was a scleral lens. Take your time with these patients, okay? Quite often they come in very frustrated. Quite often they've been through a number of different practitioners, a number of different, optometrists, doctors. They're used to changing the glasses almost on an annual basis. And just taking that little bit of extra time to sit down, explain to them their condition, explain to them why they're not getting potentially the vision that they want, why they're not, able to do some of the hobbies that they've done before. And then giving that level of service, that will be a patient with you for life. Okay. So, coming up to finishing here, it's treat everyone like it's their birthday. And we really want to make sure that these patients know that we are there to help them. Okay. We're not there to, frustrate them. We're not there to fleece them out of money. We're there to give them the best visual improvement possible by whichever means they decide, be that glasses, contact lenses, or any other method. And I'd like to welcome some questions, okay, because there are quite a lot of different tips and tricks for refracting these irregular corneal patients, not just keratoconus, your post-graft patients, your pellucid marginal degenerations, your various other dystrophies, granular dystrophies. And this isn't a completely comprehensive guide to refracting keratoconus or refracting irregular corneas, okay? And I'm still very aware that there's lots to learn here, but I decided to put this together to hopefully highlight some of the starting points that I use, and whenever a patient next sits in your chair, that it'll give you a much better starting point to go with.